I'll stay on.
Welcome everyone to Colloquium of inaugural Colloquium of this new arrangement, which I think looks great. But it's my particular pleasure to introduce today Rachel Kidman, a now long-term collaborator, probably about close to 10 years, good friend. And it took us about a decade or so to actually get into the presentation. But I'm really delighted that she's coming here. She's a social epidemiologist at Stony Brook University. She's been surrounding Penn in kind of various ways, being connected to us. She got a BA at Swarthmore College just outside, then a master in the Department of Society, Human Development, and Health at the Harvard School of Public Health, then went on to the Department of Epidemiology, and Statistics at Penn, then spent some time at Tulane, where she also worked with Bill Penn, who is connected to us. And anyway, and now she's at Stony Brook, focusing a lot in her research on adolescents' transition to adulthood, HIV infection risk, has a big project in South Africa, has worked with us on the Malawi project for a long time, where we're just bringing one project to an end and hopefully transition to a new 5-year project going forward. She's also very outspoken in a whole range of policy areas, how to protect vulnerable children. She did a bunch of cool stuff on orphans during COVID. So anyway, we're delighted to have you here to share some of the research you're showing us today on adversity and HIV risk. And I'm just good to have you here and present to us. Thank you so much, Rachel.
Thank you. I'm really thrilled to be here. It was too loud. I can see.
It's kind of an echo. It's very, very weird sound. So at least it's my perception. I don't know. It's not. You know, there's an echo. There is an echo. So
I think it's coming from those.
I don't know.
Yeah, I guess it's the new setup today.
Otherwise, try turning it off or just speak loud, maybe.
I can certainly project.
Yeah.
So if anybody needs me to be louder, just, wave me up. But I'm really thrilled to be here. As Hans-Peter said, I have a couple projects going focused on the period of adolescence. So I'm going to give you just a quick overview of 2 of those and some take-home points that have come out of those on childhood adversity in the shadow of HIV. So I'll give just a quick background on childhood adversity, and then I want you to walk away today knowing that adversity is really common in low resource areas, much more common than here in the US. And that it influences HIV risk behavior, particularly during adolescence. And that we're finding this both in populations that are behaviorally at risk for acquiring HIV, but also we're seeing this relationship among adolescents who are living with HIV and have the potential to transmit to the next generation or to a partner. And then I'll just close with a couple thoughts on implications for practice. Childhood adversity, I'm sure most of you have heard that term. It's a very broad term. There isn't one definition, but generally it's these exposures during childhood, the first 18 years, to circumstances that require a lot of adaptation. They're out of the ordinary for children. So things like abuse and neglect or witnessing your parents fight a lot. And these occur, adversity occurs across the whole life course, but when we think of childhood adversity, we're thinking about those first 18 years, childhood through adolescence. And in fact, most of the time when you hear people talk about it, they're really thinking about early childhood, right? You hear about the first 5 years being so important for a child's development, and we're really focused on, domestic abuse and neglect during that period. But actually it occurs across this first 18 years, and there's some differentiation between childhood and adolescence in terms of what that does to your development that we don't often consider. And the reason we don't consider it is that most of these studies take place among adults. We traditionally have surveyed adults and asked about their childhood many, many decades earlier. what do you remember? And we don't parse out when things happen to them. It's just a chunk of the first 18 years. And because this has been the traditional way of studying the relationship between childhood adversity and health, we're often thinking about one sort of stable exposure during childhood and much later outcomes. But I'm really interested in this period of development during adolescence and capturing the adversity that kids are experiencing coming into adolescence and throughout adolescence, and how that starts to affect their health and risk behaviors during a key transition period. So that's what I'm going to talk about today. The other thing to know about childhood adversity is it's really common. This term, adverse childhood experiences, was coined in the 1990s during that very seminal study in California that looked at adults experiencing adversity and later health. And it really was meant to capture 7 very specific types of adversity. And when they have done more nationally representative surveys to look at adults and their childhood experiences, they found that those kinds of adversities are pretty common. About 60% of adults experience at least one of these adversities, 16% experience 4 or more. A study that pooled results from over 200 studies around the world found really similar prevalence rates. So I've labeled this global adults, but it's also important to think about what we mean by global studies, right? These are 200 plus studies. 85% were in North America. 1 of them was in Africa. So we don't really know a lot about childhood adversity outside of these high income contexts. And I think that's really critically important. We cannot really make recommendations or policy or practice decisions without information from these locales. So again, adverse childhood experiences are really common. We know, at least in high income countries, that they're more prevalent in disadvantaged groups. So we want to think about what that means for low resource areas. We know that they cluster. So I've done a lot of work on orphanhood, and that's an adversity, but orphans are also much more likely to experience sexual abuse. They're much more likely to be emotionally and physically neglected. So kids tend to experience a cluster of these adversities. And we know from all the work that's been done in high income contexts that there's a really clear dose-response relationship with later health outcomes. So there's a strong literature relating childhood adversity to harmful health behaviors in adulthood, like smoking or substance use, to physical health outcomes like cancer or cardiovascular disease, to mental health issues like suicidality and depression, and even to premature mortality. So this literature is pretty robust, again, in high income countries, but when we started doing this work was really not done in other contexts, including those where HIV is quite prevalent. This is a pyramid many of you may have seen before that is created by the CDC to really talk about how adversity is embodied. Experiencing a lot of adversity in those early years can change your stress response, your immune response, there are physiological changes. And so we see as children develop social, emotional, and cognitive impairments that can either directly relate to later health or can change how they behave in adverse ways that affect their health later. And so in the context of HIV, you might think about those behavior changes as being a little more impulsive, taking risks, maybe not using a condom, and being more at risk for acquiring or transmitting HIV. This was the original pyramid, and I think it's important to recognize that adverse childhood experiences do not just arise out of thin air. They're a product of our social context, the local context, and so newer models have placed this on a more solid base that acknowledges that context. In Africa, we can, the areas I'm working in, you can think about that context as including the HIV epidemic, including sort of epidemics of violence that coexist. And those, again, are a product of our history there, of colonization, of apartheid. And so we can really think of that in its context. So I'm going to focus specifically on the experience of adversity in HIV endemic areas. I was interested in this. I started my career really thinking about the effect of orphanhood on children in these contexts, the effect on their education, their effect on their sexual behavior, and then have widened to think about childhood adversity a little bit more broadly. But there's good reason to think it might be a lot more common in these contexts. We know, again, orphanhood's more common, but kids are living in really stressed households, resources are low. And so we were concerned that childhood adversity might be more prevalent. And also that may give rise to behaviors and circumstances that might perpetuate HIV transmission. So more risk-taking behaviors in this population. So we might have this cycle between these two. And I was in particular concerned about what was happening during adolescence. Adolescents are growing as a population at a tremendous rate. And this is a period where they're entering their first sexual and romantic relationships. So how is the history of their childhood and their current experiences with adversity structuring their behavior during this developmental period? So I'm going to give a couple examples. One is from the study that we're doing here with many of you that's located in Malawi among a general population of adolescents at risk for HIV. And the other is a population study, a study in South Africa with a different population. And that's adolescents who are living with HIV and then some of their peers. This room may be much more familiar with Malawi than most audiences I would speak to. Those who aren't, it's this tiny little country in red right here in southeastern Africa, and it still has a fairly high HIV rate, around 8% among adults. And this is where the Malawi Longitudinal Studies of Family and Health that you all are familiar with is taking place. And along with Hans Peter, we wrote a grant to ask whether or not childhood adversity exacerbates HIV risk among adolescents in this context. So in order to generate our sample, we built on the tremendous 20-year history of the MLSFH. We worked with the same families. Hans Peter pulled out which families were likely to have adolescents in 2018 based on household rosters. And we built off of the trust in the communities that, again, had been created from this study for the last 25 years. And we interviewed about 2,000 adolescents aged 10 to 16 in 2017 or so, and their caregivers. And we came back 4 years later and interviewed them again during later adolescence. This was a huge team effort. This is just some of the people who worked on this study, on specifically the adolescent aspect of the study. We have an amazing team in Malawi of interviewers, drivers, HIV counselors, managers. So I just want to have a shout out to them in the middle of the presentation rather than an addendum at the end, because they are so important to this effort. This is one of our interviewers in 2021 with some precautions for COVID. He's masked. We did our interviews outside where the adolescent could sit privately with an interviewer and do a face-to-face interview where nobody could hear them, but where caregivers and other adults could still sort of see them for safety issues. And they would do a long interview with the field worker. And then a couple days later, we had an HIV counselor who would come by and do a rapid HIV test and an HSV2 test at follow-up. One of the main things we were interested in, of course, was adverse childhood experiences. What you see here on the screen are the traditional ACEs that are collected in the US. So we have physical, emotional, and sexual abuse. You have physical and emotional neglect. And then we have indicators of household dysfunction like mental illness in the household, domestic violence, divorce in the household. In about 2010, the WHO started thinking about surveillance outside of the US and what that would look like, and brought together stakeholders to develop a new tool. And that tool, the Adverse Childhood Experiences International Questionnaire, also includes parental death, orphanhood, acknowledging that that's pretty common and clearly an adverse childhood experience. But also there are some things outside the household, like bullying by your peers or witnessing a lot of violence in the community or being involved in an area that is actively at war that are adverse childhood experiences. So we collected data on these 13 experiences in our study, and that was our main predictor through this study. This is just a description of reported adversity at baseline in blue and follow-up in red. And you can see that physical and emotional abuse was quite common, neglect was common. There was a lot of domestic violence in the household, a lot of violence in the community. So fairly prevalent adversity. And I want to stress that when we compare that to what is reported in high income context, we see that it is much, much more common. Okay? Almost universally, children experienced adversity. There were at least one. 72% reported 4 or more. Now, I'm including 4 additional adversities that aren't always in these US surveys. So even if I take those out, we're still seeing really high rates. Okay, much higher than in the US. And I'm going to jump ahead to just say that in the study I'll describe in a minute in South Africa, we saw really similar rates, incredibly high adversity. And during this period that we were investigating adversity, a number of other studies looked at this in South Africa, Nigeria, Kenya, and they found very similar prevalence of adversity.
A question on kind of community violence. So, as you know, our impression is always that it's a strikingly peaceful country, which contradicts with your experience of community violence. I was wondering, do we know a bit more what kind of community violence that is? Because it's clearly not a war, like a war-torn country or you know, ethnic groups violence.
In Malawi, I don't know. I mean, I know you say it isn't violent. In prior years where I've worked there before the MLSF page, there was much more violence, which I know talking to people, it's gone down a bit. But I think there's also witnessing a lot of domestic violence around the community that's out in the open. So I don't know, but it'd be good to probe with qualitative research if anyone ever wants to do qualitative work with us. I'm very quantitative, but I think that's a great question. And we do have a qualitative component in the South Africa piece to get at these more nuanced questions. And in that context, there's a lot of gang violence and a lot of violence just out, you know, really in the community we're working with. As well. In that case, it's mostly gang violence.
And not like political violence.
In Malawi, no, not that I know of. There's not a lot of political violence. In South Africa, there can be political violence though, definitely. And there's been wide-scale looting and there was a lot of violence actually during the period we did the study. Our clinic was vandalized, our study, you know, computers were stolen and things like that. So absolutely, yeah.
So related also to these differences that you reported. So when you adopted your instrument in Malawi and South Africa, did you do any culturally appropriate adaptation of what is, for instance, emotional neglect? Because we know that there are a lot of differences, and what we would consider here as an emotional neglect or physical neglect might not be considered necessarily as an emotional or physical neglect in Malawi or South Africa. So did you do this cultural modifications?
In part because, I mean, we talked about it at the time, but I think, you know, one of my feelings, at least here, and we adapted the language a bit, but not the meanings, was that we were trying to come up with a standardized scale that could be used across to compare to other countries. So there's a pro to adapting it, and there's sort of a con in that you lose that ability. But if you recall, we had those vignettes where we would ask about their interpretation of a situation and whether this constituted physical violence, you know, from a mom to a kid, and we had them gender matched. And almost universally, the kids recognize the situations we put out there, the little vignettes, as whatever kind of violence we thought we were describing. So I think we have a little bit of information that this is in fact in line with what they would consider. Whether or not it's out of the norm and has the same effect on kids is a different question, and an interesting one, I think, for us. So this study was linking adversity to HIV risk. Our main outcome was supposed to be HIV. You know, we measured our baseline, we're gonna look at incidence. We had very few cases, which is awesome. In general, not great for the study, but awesome, you know, overall we'll take it. So we can't use HIV as our outcome. We did take a measure of herpes, HSV2. We also have a lot of behavioral measures like early sexual debut and condomless sex, which we can put into a composite risk score of 0 to 4. So I'll be focusing on some of these other behavioral outcomes in the next couple of slides. So this is just a description. You can sort of see cumulative adversity on the bottom and HIV risk on the other axis. And there seems to be a dose-response relationship there. And if we probe more closely with modeling this and adjusting for appropriate confounders, when we look at what the kids reported for adversity in their early life at baseline and their behaviors 4 years later, we do see some relationship for girls between early adversity and their behavioral risk. And we certainly see for both boys and girls a relationship between early adversity and their intimate partner violence victimization. But we're not seeing a consistent relationship for boys in any of these indicators. However, at follow-up, when we ask about their adversity over their lifetime, which now includes that adolescent period, and we link that to their behaviors at that late adolescent period, we see a much clearer, stronger, more consistent relationship. And so we do see a relationship between adversity, and this is looking at the most experienced, the highest tertile of adversity versus the lowest here. We do see a relationship in behavioral risk for both genders, IPV for both genders, and we had asked about STI symptoms among girls. So we're seeing a more consistent relationship there. So, from that Malawi study, the take-home points at least are that childhood adversity is really common in this context. We need to be concerned about it. We need to start probing more, as Ileana, pointed out about what that means. But this is a first step. It was related to later behavioral risk-taking for girls in IPV for both genders, but it seemed to be the more recent adversity accumulating in adolescence perhaps was really what was driving the immediate behavior during that developmental period. So rather than always thinking about early childhood, we also need to be thinking about what kids are exposed to at home and in the community during adolescence and how that is shaping their behaviors. And we're hoping to continue this project. So this is just a shout out. We have lots of data, but we also hope to be continuing it if people are interested to, again, look at these same adolescents as they age into emerging adulthood, as they partner, as they have their own kids, and really thinking through what their early life histories mean for that family formation period in their early 20s. So jumping to South Africa now, going a little further south, we have a study that is located in Soweto. Soweto is an informal township just outside of Johannesburg, characterized by a fair amount of violence in this area. South Africa is home also to huge population of adolescents, which is growing across low and middle income countries, certainly. But importantly, South Africa specifically is home to the largest number of adolescents who are living with HIV. So if we care about transmission dynamics within adolescents, this is a really important place to be locating a study. And we can only really think of interventions for this population if we're working with this population and have data from them directly. So this is a study called Samansano, or Walk With Me. These, again, are some of our wonderful staff members, recruiters, interviewers who are involved from the perinatal HIV research unit at Witwatersrand. This unit is located in Soweto specifically. And it is also focused on adversity and risk for HIV. The first risk factor is low medical adherence, and this relates to the population living with HIV. If you're not taking your meds, and honestly, it's really hard to get adolescents to take their medication, especially in this context with HIV. If you're not taking them, you're not going to be virally suppressed. And it's important to have viral suppression because if you're virally suppressed, you cannot pass on HIV, no matter what your behavior. So the first thing we're looking at is whether or not they're taking their meds. That's a behavioral risk factor. For the population with and without HIV, we're concerned about condomless sex, and we're concerned with IPV perpetration because that's really seen as a main driver of HIV in these contexts. And we're very much concerned, again, with both HIV positive and HIV negative adolescents. This is a study focused on boys exclusively because boys have most of the agency at this age in relationships. They're the ones deciding whether or not to use a condom, and they're the ones perpetrating the kinds of intimate partner violence that can result most likely in HIV transmission. So we have a sample of 500 adolescents, half of whom were living with HIV since birth and half of whom were peers recruited nearby to where they are getting care. They are 15 to 19 at baseline. And because we're focused on sexual behavior and relationship dynamics and wanted to capture that, they had to either be in a relationship or be having sex at the time we recruited them. We recruited half of them from HIV care clinics throughout Soweto, and around each one, we had a catchment area where we recruited peers who were HIV negative. They came into the clinic and did a survey on a tablet privately with a staff member nearby. They had a medical visit, so they did HIV testing for those who thought they were negative. We did viral load testing, STI testing, et cetera. And then they were trained on how to do a mobile survey on a smartphone we gave them. They went home for a year, did the survey when we beat them every week, and came back and did another baseline, follow-up survey and clinic visit at the end. In this particular instance, we have a lot of qualitative data. We have 50 in-depth interviews that we're just starting to go through. We're just starting to go through all of this data. Just finished up. So if anyone is interested, we have a ton of data. I'm going to give you a little peek, but like I'm always happy to collaborate. We have more data than we could ever, really use ourselves. So just to give a peek at this population, in orange, you see some data from those who are living with HIV. You can see about 80% were not taking their meds, at least 90% of the time, which is sort of a clinically meaningful cutoff. So really for adherence, that's actually really normative for this group. Unfortunately, 70% were virally suppressed, so they can't pass on the virus to a partner. About half of the overall 500 were consistently using a condom. And about 40% said they had perpetrated either sexual or physical intimate partner violence in the past year. So again, I'm really interested in this relationship between adversity and risk behavior. Here, for those who are HIV positive, I have a composite indicator of condomless sex with a detectable viral load. Because if you have an undetectable viral load, your condom behavior doesn't matter, you're not passing it on. So you have to have both of these risk factors to have high-risk sex. And we see that for each of those additional 13 adversities, the odds of having this kind of high-risk sex increased by about 33%. When we look, yeah?
I was just wondering, do you, and you might have said this already, but do you know how these adolescents contracted HIV?
This is a, yes, this is a group, yes, that has perinatally acquired HIV. We proposed to NIH that we also have a group of behaviorally infected adolescents, and they said, we don't want to give you that much money. So we didn't want a mixed group because we want to be able to really say something. And those are very different groups of adolescents, those who have grown up with HIV and those who acquired it through their behavior during likely adolescence. But that's a good question. Yeah.
No, and among minorities in the US, it tends to be concentrated among men having sex with men.
Yeah.
And do you see any of that?
No, I mean, this is more of a generalized epidemic. So it is going to be higher in almost every country among any marginalized group. So men who have sex with men, sex workers, whatnot, often minorities for whatever that is in that group. But in this case, it's such a generalized epidemic that you see it, you know, among everyone. And this population, again, we did ask about sexual identity. I don't know how great the data is among adolescent boys, but this is sort of a general sample.
Whereas if you could tell us more in detail how you asked about IPV.
Sure. So we used the Violence Against Women let's see, interview, which asks specifically about acts. It doesn't say like, you know, are you a victim of intimate partner violence? It says, so, you know, has any partner ever hit you in this way? Has any partner ever threatened you or called you names? Asked a bunch of specific questions. And then we used a sexual experiences survey, which, so the Violence Against Women, I should say, is about victimization. There wasn't a lot of good surveys at the time we started about perpetration, so we adapted that to ask about perpetration. And we made it gender neutral for all of these things. You know, because a lot of these instruments assume it's a man perpetrating violence against a woman. And so we have made them gender neutral. And then we've adapted them for perpetration. And then the sexual experiences survey is about sexual violence perpetration specifically. So those are the instruments we're using. And I think I was about to go here. So we're seeing the same kind of relationship when we look at intimate partner violence perpetration as outcome among the group of 500. Each adversity really increased very consistently reports of perpetration against a partner. And I'm going to focus on intimate partner violence for the last couple minutes to explore this relationship in a little bit more detail and start thinking about timing a bit more. Because the question we traditionally ask is, you know, which boys are using intimate partner violence, or which, you know, groups of boys are most likely to have condomless sex. And it's about, you know, this static risk and outcome. Right, and here we're finding, okay, which boys? Well, it's the boys who have a history of adverse childhood experiences who are most likely to use violence, who are most likely to have high-risk sex. So that's which boys more generally. But it's sort of assuming that that risk doesn't change. And I think that's a product of most of this field having come out of adult surveys, where we just have one measure of childhood adversity and one measure of how you're doing later in life. And we're comparing those two. But the reality is a lot more dynamic, right? So whether you got in a fight with your mom and she used physical violence against you changes day to day. Your experience of violence changes day to day, not just through developmental periods, but day to day. And we already saw that adolescence seems to be a really important period for recent distress. But also your behavior changes day to day. Right? We're measuring consistent condom use because people don't use condoms every single time or not at all. Sometimes they use a condom with their partner, sometimes they don't. Sometimes they use violence, sometimes they have a lovely date, right? It changes. There's a dynamic nature to this that we just sort of ignore. And so we, in this study, we're trying to go one more step and think about that timing issue and say, okay, why is it that a particular boy uses violence on some days and not on others? So the research question is just, are boys more likely to perpetrate IPV on days they experience adversity themselves or violence themselves? Is there an acute relationship here? And for this, you know, we're honing in on these weekly surveys that we did with the boys. We collected these surveys, you know, while they were out in their homes, schools, community. We would, you know, send them a quick prompt and they'd complete a 2 or 3 minute survey once a week for a year. So we have a lot of assessments of what was happening in the past 24 hours. So a lot of little data points. And they, you know, had some incentives for completing the survey every week. They got airtime automatically. There was a lot of technical and psychosocial support available to these kids throughout the year. We didn't get great compliance, I'll be honest. Like, these are adolescent boys in a very sort of difficult circumstance. And this really hadn't been done in those kinds of environments before. So we also did a lot of qualitative work to try and refine this as we went as well. But we did, in those 2 or 3 minutes, asked them about what had happened in the past 24 hours in terms of experiencing physical, sexual, or verbal violence or seeing something in the community. And we also asked whether or not they'd seen a partner. Did you see your romantic partner? Did you have sex? And if so, we gathered information on IPV perpetration. We also have information on condom use and sexual behavior and things like that. I'm going to use IPV as an example here. So we can use this data to just come up with better estimates to look between boys. Right? We can say, okay, in his real life, without worrying about recall bias, because we're just asking about the 24 hours, immediately before the survey, we can come up with better data to answer the question about which boys, are using violence and link it to their histories. But what I'm really interested in is why this particular boy used intimate partner violence on some days and not on others. And we can hone in on that a bit more with this data. So we have over 12,000 surveys that were submitted correctly. We have about 5,000 where they actually said, okay, I saw a partner, a romantic partner, my girlfriend, a casual sexual partner, whomever that day, and we can assess intimate partner violence. And we use generalized linear mixed effects models so that we could separate out the between subject component. So, what is it about the average exposure to violence and its effect on, which boys use violence, and the within subject component. So why did that boy on that day perpetrate violence? Was there something also happening that was different from his norm that day? And across all of those 12,000 surveys, we see that boys reported violence in about 9% of those. So if you reframe that, that means on any given day, 1 out of 10 boys is experiencing violence of some sort in this context. So that includes physical, verbal, sexual violence, and witnessing violence in the community. When we look at physical IPV perpetration, we see that there's a pretty clear pattern of having experienced violence that day and then perpetrating violence against a partner that same 24-hour period. So it seems to increase the odds about fourfold. And it's highest if they have experienced sexual violence last 24 hours. And we see the same thing when we're looking at sexual IPV perpetration. So if you experience violence, any sort of violence, but particularly sexual violence, you're much more likely to also engage in perpetration of sexual violence in that 24-hour period. Now, this isn't perfect. Like, it's a snapshot, but these are still snapshots. They're still cross-sectional snapshots. So we can't quite rule out like bidirectional violence, which is why some of the quantitative data that we collect, as well as some of the qualitative data, is really important to start teasing out why they're engaging in violence and whether or not they're recognizing these triggers or if it's really bidirectional. But so far with these analyses, we're showing, again, that adversity affects HIV risk behavior. This is true in a general population sample, but it's also true for kids who already carry HIV and can transmit it to partners and offspring. We got really strong data with some limitations from the mobile data approach. And in addition to having strong reverse data, it gave us insights that we wouldn't otherwise have in a traditional survey because we're looking at that acute process. So boys who experience really recent violence were more likely that same day to perpetrate violence. And that gives us a different time frame for when we might want to intervene in a different set of interventions. So let me give you an example, and this is my last slide because I know I'm supposed to have a clock, but I know I'm supposed to be very, very on time. But this is my last slide, and then we can talk generally. So we want to think about primary prevention of adversity, and we want to think about secondary prevention. So in terms of primary prevention, there's a lot of really good evidence that parenting programs work well, not just in high-income countries, but they've been adapted to a number of low or middle-income settings where they work equally well. This is one example of there, but they reduce conflict with kids. They reduce, verbal and physical abuse not just to young kids, but there are programs targeted to families with adolescents. They reduce violence against adolescents, and they reduce violence between parents, so you're not witnessing so much violence. So there are proven, fairly cost-effective means for reducing childhood adversity, and this is one example. But then there are always going to be kids, there's cohorts of kids now who have experienced adversity, there will be cohorts in the future, and we have to think about how to support them and sort of interrupt that cycle before they have adverse impacts on their health. And in particular, what has stood out for our staff at the clinic, our community advisory groups, our adolescent advisory groups, is this issue of sexual violence, particularly in South Africa. Nobody talks about violence against boys. It's highly stigmatized, particularly sexual violence, and there's no support for them. All the programs on gender-based violence are really thinking about girls. They're targeting girls, and messaging is around girls, and so there's no real support. And the HIV, doctors and staff would say, we don't even ask about this, doesn't occur to us. So really just increasing awareness and start tailoring some services and availability for boys who are experiencing violence, which is incredibly common, right? Day-to-day violence, 1 in 10 kids every day is experiencing, 1 in 10 boys violence. And really thinking about what that means for their health and making support available to them is going to be critical. And then finally, this seems to be an issue that has different time frames. Certainly what's happening in your childhood or the few years before your behavior matters, but what's happening the day you're seeing your partner or making these health risk behaviors matters too. And so thinking more about what that means from an intervention standpoint, does that mean we need to think about emotional regulation and how boys cope? They can experience a trigger of violence and have a healthy way of processing that and problem solving so that they are not then taking it out on a partner or engaging in risk behaviors that could endanger their health in the future. Thank you guys for having me and for listening. I want to thank our participants in particular for giving us all this really rich data. If folks are interested in learning more, I'm happy to answer questions now, but my email's up here too. If something is sort of brewing in the next few days, you want to reach out or you want to think about collaborating, please do get in touch with me. Thank you.
So I had a question about how these parenting interventions would look like in Malawi. I really have no intuition how, an intervention that would try to improve parenting behavior. Doesn't look like.
Well, I think there's training of either staff or community members, who are brought up to that level. There are good programs that have been adapted to South African context. I think you'd have to adapt them, obviously, to the Malawian context. But you have group sessions with the parents. You have some sessions that are parents and kids, but it talks about good conflict resolution strategies, communication, why violence or child discipline, I should say, physical child discipline can adversely affect children. So there's a whole structure of activities that they do either with the parents or then later with parents and adolescents together to encourage healthy communication. That seems to work in a number of RCTs across a couple different contexts. And they've done some costing. I don't recall what that is, but it's quite affordable when you think about the downstream effects that this is having on kids. So.
And do you think that just based on what your experience has been, do you have any sense of whether parents know that it's wrong or it's just they know it's wrong, but we do it anyways, or is it just culturally acceptable and they have no idea that they're actually inflicting violence in a way that could have adverse effects later on?
Yeah, that's a good question. I mean, I don't know the answer to that. We could ask that here too, right? Like I don't want to treat this as if Malawi and South Africa are unique. Adverse childhood experiences are higher there, likely because of, again, a history of violence inflicted on those countries. But this kind of situation happens everywhere. And I don't know. I mean, I do think that norms can be very different. So child discipline can look very different in places that isn't necessarily negative. And I think there's also a lot that people know isn't great for their relationship with their partner, their relationship with their kids, but they don't have the coping skills or information to do it a different way. But that's a great question. I don't know.
No, I'm interested in this, the measurement of childhood adversity and how to do research in developing countries for childhood. Because you did the right thing. You kept asking the same, taking the questionnaire, stuff like that. But it shows that it's somewhat universal if you measure it the way you measure it in rich countries. So, but thinking about what are the dimensions that might actually separate a child from being really adversely affected in this context, what would be those? What do you think are the things that you mentioned sexual violence, which seems that maybe that's instead of thinking about how we could measure this better or it's context specific.
Yeah, I mean, that's a good question. And I don't think there has been enough work. I mean, this instrument was piloted in a number of different countries. And I wanted to keep it because of that. But we also did these vignettes because we were also thinking, well, some of these things might be normative. And if it's more normative, like, physical child discipline, which we would classify as abuse, but they may not. You may not see the same stress response from the kids. You may not see the psychological impact from that because it's normative. And so I don't think I have the work to say which is and isn't. I think sexual violence certainly is less common and seen as very severe and adverse. But I think there's a lot of work to be done. I don't see across the board the same strong associations always between adversity and some of these outcomes that I would have expected based on the literature that's mostly in high-income countries. So I think that's one of the areas. We've tried breaking it down in some analyses by the types to look at what really seems to drive it, but that can be messy. You can separate it from threats, like abuse or, whatnot, to deprivation, and there are arguments for that. I'd say the theory and the concepts around how to measure this, there's just a ton of debate right now. And then if you layer in how to do it in a new context, that's even more difficult. But these are great questions because I think we need to think about it, and we can add, hopefully if we're going forward with this, we can add other measures. And we certainly plan to do a better job involving stakeholders from the get-go on the next project, who I think, we do talk to folks and try to get input, but I think we need to do a much better job of bringing in the right people to say, you're not measuring this concept or that, and really pushing ourselves to not change the original one, because I like having that comparison that I think is lacking so often and making it hard to say, we really have to focus here. It's not just a difference in instrument, but I think we can add pieces around that to get at some things that we may not think of as adversity here, but they do, or perhaps get at whether or not they really perceive some of these as non-normative or extreme.
I have a question related to some of the things you said earlier, that we generally group all these together, the timing, what happens in childhood and what happens in adolescence. So do you have the data to parse it separately? So could you look at separately or what happened in childhood? Because that was the big argument you made, that people lump them all together, and it would be nice to, in your study, if you could separate them.
Not entirely. I mean, we had sort of hoped to do that, and we went back and forth on how to, whether kids could really think back, because we were getting them at early adolescence. Could they think back about what ages they experienced these? And we decided that probably wasn't feasible to get reliable data. And so we have a measure of what they'd experienced up until, that age. We have a past year measure, so we know about what they're experiencing in early adolescence, and then the same with later adolescence. And if we follow them, we'll get them to look back at the full 18 years. But we don't have the best data for that. Yeah.
So, just one thing, I thought a lot of, I guess one of our find was it's really the kind of fairly recent one that matters. I guess one upshot of kind of the analysis was the earlier one. Anyway, we found much less on the early one, and it's basically a lot of it driven by recent one, which may be a function of the history, but just empirically, the recent one picked up a lot of association.
Yeah, absolutely. I mean, we had, or at least I had hypothesized that early, experiences were going to be so, fundamental as a driver for these risk behaviors later, that it was going to be the early pieces. And we were surprised that it really seemed to be the more recent stuff that was going on in their lives. But I wish I could parse the timing a bit better. I mean, we had tried to do that and come up with ways and tried to look at the data about critical periods, and we haven't had a lot of luck really figuring out the right methods for that. We did play around with it.
So along the same lines, I'm curious because you said that you in the South Africa study, you have 2 samples, right? I mean, you move from 2 samples.
Yeah.
And some of the kids, some of the boys have HIV or HIV positive, some are not. Do you find any differences? Because one could consider that like a huge adversity, right? Growing up with HIV. So I wonder if
So we thought we would see more adversity in the boys who were living with HIV, like they'd be picked on more likely with, by peers, or maybe a lot of them have lost parents. So orphanhood's probably a little bit higher in that group. We thought though that we would see a host of adversities within them that we didn't see in their peer group. And in fact, we actually see a little bit more adversity in the it does not have HIV, just a tad, but significantly a little bit more, which was very, very surprising to us. And we are absolutely running these things with stratified analyses, and we do see, in fact, that adversity seems to have a slightly stronger impact on, for example, intimate partner violence perpetration among those who do not have HIV, surprisingly. And we have some cognitive we have a bunch of cognitive data that I mentioned as well that we collected, and we're not seeing as many differences as we thought between these 2 groups, because one did have HIV, but they're all growing up in this informal settlement together where there's a lot of violence, a lot of food insecurity. When the boys come in and talk, I was very worried about the ethics of all this. We have counselors available. We have, they are debriefed by a social worker. We have, a push of a button, somebody will call you on your mobile phone. They actually enjoyed talking to someone. They're like, nobody's asked me about these experiences. This is new. They liked having the support. And so, and I started worrying about some of the high levels of suicidality we were seeing, and like the nurses and doctors are all like, this is every day, this is this population. And I'm of course looking at the literature, comparing it to studies in the same area and finding that yes, this is in fact very much in line, because this group is just really disadvantaged and living in a really tough, challenging sort of environment. So we're not seeing the differences that I thought we'd see between the HIV, the kids living with HIV and those who aren't. Yes.
I have a very kind of broad question about your approach as a researcher to studying inequality.
Yeah.
So on one hand, you do this great work comparing ACEs between like the US and South Africa and Malawi, which just signals that the immense like global inequality there is. Mm-hmm. And now you're talking about these extremely like specific adverse experiences but it's kind of difficult to parse where there's like local inequality and who is most vulnerable and how should like policy interventions target the most vulnerable. And so I'm curious about how you like think about studying inequality, both from like a global comparative perspective and like a local targeted, like who do we need to get help right now perspective.
Yeah. Well, so I have only, the US data is not mine. In fact, I've only ever done one US-based study on COVID and orphanhood in the US. So that is just, there's a comparison for myself to think about, you know, what we're seeing. And I do think it highlights inequality, and we're just not getting resources to kids who need it. It's not on the agenda in most places. I think the violence against children studies that were funded by the CDC in a number of different low and middle income countries brought some of that to the fore, and some of these countries now have more policy, at least on the books, about this. And there's some resources, but I don't think there's as much attention and funding. Maybe there's attention, but there isn't as much funding available in all of these contexts for these kinds of programs, and there should be. In terms of targeting within these communities, I don't know that we should be. I think so much of this is so common that you're going to waste money administratively and time trying to figure out which kids to target and bring in. I think you need universal sort of programming that's available, parenting programs that are available for everyone. I think most families could benefit. Not everyone's going to elect to do that. But I think, you know, it's probably least stigmatizing if it's a generalized approach. And I think what we're seeing is that the kids who are living with HIV aren't really experiencing vastly different childhoods than those who are living without HIV. And so, you know, if we think about generating resources that support kids who experience sexual abuse or abuse at home, those are resources that should really be available and more universally targeted to communities, not to individuals.
Yeah. I just have a question about reporting requirements. So collecting information on ACEs with minors in the US brings reporting requirements with it, so that if you're collecting data on these topics, you need to report to local officials if you have evidence that children are experiencing domestic violence. Does NIH have any kind of requirement like that for international research? Do you have any obligation to report on what you learn about ACEs?
I don't think so. We don't ask about what's specifically happening right now. This is sort of past year, past.
So even with the South Africa?
No, the South Africa is past 24 hours, so that's current. So Malawi don't. We follow the guidelines that are set out for research in South Africa. And we have an IRB board at Witwatersrand and 2 community advisory groups there, and a bunch of counselors and doctors who work with us. And I'm not aware, which is a great question, of any reporting. I mean, we've talked to them about reporting because sexual activity under South Africa law is, there's some questions about reporting, you know, early sexual activity and different things. So we've probed that in detail. I haven't probed this in much detail. And everything goes into immediately a non-identifiable, you know, database. With no names. We have, again, as I said, counselors and social workers literally right there debriefing them after everything and available to call all the time. But I don't know of any specific regulations. It's a good question.
Final question on, so one reason we're concerned about this ACEs, I guess, is lasting, you know, lifelong consequences. And so based on your snapshot on adolescents, what do you think are the mechanisms that are going to have lasting HIV infection? Presumably is one, but anyway, so I guess based on, you know, monitoring, studying adolescents, where do you think these ACEs might have the longest, the most severe lasting effects?
I mean, I think the areas we see the most consistent and strongest effects are mental health and violence perpetration. So we see a lot of, unfortunately, depression and suicidality in these populations. And that's not something that goes away. That's something, you know, that appears in adolescence and is going to carry forward and affect them over their life course. I mean, I think there's a lot of things that may be really important later on that we're not seeing because I'm just focused on this period. And I think, you know, rather than just, you know, whether they're using condom, I think how they relate to partners and the use of violence against their partners and possibly their children, in future years, I think it's going to be really critical. So I think they're setting patterns in adolescence that are going to carry forward. And that's, something that hopefully you and I will look at as they go into their 20s in terms of how they form healthy or unhealthy relationships with a new spouse, and how they parent their children as well.
Okay, on that note, thank you so much.